here. I'm just talking off the screen. So, because Brantley and I are going to go back and forth. So our selection process. So Brantley started in September of 2014. Is that right? Okay. So 2014, and we had our previous EHR was Insight, which was a NetSmart product, which at the time we kind of thought we were happy with. I think it was a little bit of Stockholm syndrome. And Brantley had said, you need a new EHR, and we thought you've lost your mind. And we probably had some other very colorful adjectives to add to that.
Yeah, so it was becoming pretty difficult. I realized how time intensive. You practically need a full-time IT person on staff to be able to work it. So that's at which point I thought, okay, well, there's got to be a better product out there that we could use that's easier. And then if something was to happen if you didn't have IT support, that you could easily keep on going rather than coming to a grinding halt. So I probably over the course of about 3 or 4 months, I contacted pretty much every EHR company I could find. And then I was running across the problem where pretty much all of them seemed to be geared towards hospitals first. And I wasn't prepared to try to fit a square peg in a round hole and try to get a hospital grade system to work for public health, because it does far more than what we would need. And it was just by luck. It was my last ditch effort. I came across Patagonia Health, and then so obviously we went with them. But so we did a go-to meeting. I was impressed with the initial meeting with I believe his name was Tom Power. Once I got past the reviews, making sure it had the baseline functionality that I knew that the system needed to make, I then called in all of the nursing supervisors and pretty much the entire team on that first slide, which kind of consider our power user group, and brought them on. They were also blown away by what we could do with Patagonia. Probably a few months later.
Oh, I don't even think it was a few months. I mean, well, it could have been.
Yeah, maybe a month or so.
Yeah.
I believe it was Ashok and
Tom.
Yeah, Tom flew out here. They did another all day long. I think it was actually a day and a half demo.
2 days.
We pulled in some nurses too to get their first impressions. They took down a lot of notes on what our processes were, some of how our state systems functioned, like our immunization system. From there, we decided we got a list of counties that were already on Patagonia Health. We did a bunch of cold calls, try to get a hold of various directors, get their first impressions on it and how they felt about it. And pretty much everybody had nothing but good things to say.
Right. Brantley and I spent weeks making calls, making follow-up phone calls, scheduling calls with directors and tech staff and public health nursing staff, and we came away thoroughly impressed with the reference checks that we got. Oh, and then after that, so once we had done that, we wanted to do our due diligence. We scheduled, with the help of Patagonia Health, with 2 user sites in North Carolina, Jackson County and Cleveland County, who were fantastic, wonderful, gracious, hosted us for a day each. North Carolina was beautiful, and we had a great time there. And we came away even more impressed with how Patagonia Health would be able to meet our needs. So then at that point, we returned to, and sorry, Monique, it's Nevada. Everybody says Nevada, and we're like, it makes us cringe, but that's okay. So it's Nevada. So we returned to Nevada. I met with my administrative health services office, and we put together, how are we going to pay for this? So we figured all that out. Once we figured out, that now we do want this, we have a way to pay for it, we needed to execute the contract. So we went to, I worked with my fiscal compliance officer. We wrote up our board item. We got a contract between Patagonia Health and the Washoe County Health District, and that went to our board in October of 2015. And I have in my notes, general excitement ensued, and we really were quite thrilled because, well, I'll just say that our previous EHR system was far from meeting our needs at that point. So we were just practically giddy with being able to move on to a new EHR. So then we moved into the implementation process, and in November, Tom organized a kickoff call and an implementation plan with Patagonia Health started to take place, and we started to develop a timeline. One of the things that we knew pretty much out of the gate is that we wouldn't be bringing over our financial records. They were pretty much a mess in our previous EHR, and I'm turning it over to Brantley for the next point.
Yeah, so then towards the beginning of 2016, I met with over a series of go-to calls directly with the developers. We kind of tore through the database, all the various modules, drop-downs, and pretty much everything we could come across and try to find which data could easily and feasibly be moved over. We couldn't get everything. It's just not going to be possible, but we tried to get the core medical records moved over. So we knew right off the bat we couldn't get module data out just because it's so interlinked and there's so many various drop-downs that then branch off into other tables. But we did develop some scripts to kind of put all that data into just one simplified PDF file and then migrated that all over with the patient's charts. We also had to consider Nevada's revised statute on data retention laws for medical data. It used to be as simple as just 5 years, and we had no more obligation to hold on to it, but Nevada's law was since changed, and so now it's far more difficult, especially for how long we have to hold on to younger patients' data.
Records for minors.
Yeah.
All right, so implementation continued. So in March of 2016, the various teams started working on workflow and processes. And when I talk about individual teams too, I should probably tell you, so our clinical programs that we brought over were immunizations, family planning, STD, HIV, or as we call it, sexual health, tuberculosis, and our maternal child adolescent health program. In April, Patagonia Health was on-site for staff trainings, both clinical and practice management. We had Debbie and Felicia, and they were fantastic. So in April, they were here. We did do training of management, clerical, clinical staff over the course of 3 days. Our initial trainings were built into the purchase price of the contract, and I just wanted to let everybody know. So for subsequent fiscal years, I did build into my budget and an agreement with Patagonia Health. We have my budgeted for up to 6 days of training into our budget, and we definitely plan to use this as we need to support staff and improve our knowledge. That's something that we did poorly with our previous EHR, so I wanted to do it right out of the gate for this time. And I just wanted to talk a little bit about managing change, and Ashok makes a really great point when meeting with, I would say, prospective clients, or at least he did with us. And he talks about a three-legged stool, and managing change can be difficult, and I just wanted to speak to that with regarding training. So we have some staff that are incredibly detailed and might have a bit of anxiety when it comes to making changes, and so that could really slow down your training. What we try to do with subsequent days or sections is to talk to staff prior to the trainings and to just take the training in and then ask questions after, because we really believe that the majority of the questions are answered along the course of the training. The trainings are very thorough, very, very detailed, and we believe really met most everybody's needs. So then, yay, we go live. So May 23rd, we had our go live preparation. So we closed our clinics that were scheduled to go live, and I'll explain a little bit more about that when I say that the clinics that were scheduled. We did inventory reconciliation, entered everything. So we took everything out of our previous EHR and entered it into Patagonia Health. And then we conducted a mock clinic to just give our staff just one more good run. And then on May 24th, 2016, we launched our immunizations, maternal child health, and TB programs. And then in June, we launched our immunization HL7 interface, and Brantley will tell you a little bit more about that.
Yeah, so we actually got our HL7 interface up pretty quickly right after the go live. I think it wasn't more than 2 to 3 weeks. We were on the older 2.5.1, or I'm sorry, 2.3.1 version of HL7. So we were finally able to jump to the latest version of 2.5.1 that our state supported. And then we have also since moved to the new CDC eligibility codes that were put out in 2015. So we're probably one of the first counties in our state to move to these new codes. So it's just kudos to Patagonia on being able to move quickly and add these features and these new data reporting requirements.
So then what about our other programs? So I told you about our other programs that we have. So our next steps really were, to start working on those. What we ended up doing is literally the week before is we pulled the plug on the go live for STD, HIV, and family planning because we were still having some challenges with data collection and current reporting. So the implementation team worked diligently with Patagonia to ensure that all necessary data elements would be addressed to ensure necessary reporting requirements and mandates basically from our funders that those would be met. So at that point we built mock-ups, we shared HIV federal reporting requirements with Patagonia Health, built inside and outside labs specific to the Washoe County Health District, and we had there were subsequent Patagonia Health software releases that worked toward meeting our needs. And this all helped move us in the right direction. So we worked with them to develop STD HIV widgets. We had to recreate some of our forms, super bills, lab requisitions, and labels. We had to adjust our workflow, and we had to match our medications in eScript to inventory, and if it was not matching, we could not dispense. So all of these were really some pretty big changes to us and took us some time. So then what we ultimately ended up with was a staggered launch. We really would have never guessed this, but there really were a number of advantages or upsides to this.
Yeah, so then also for the billing, I've probably been involved with the billing since the get-go of trying to get it started again with our last EHR. So even though I'm IT, I've had a huge hand in learning all about CPT, HCPCS, diagnosis, and all that other stuff that I probably would have never thought I would learn. We had a relatively new billing team as well, so none of us would be what you consider, I guess, certified professional coders, I believe is the certification. So this has been a huge learning curve for all of us, but we've actually done pretty well for ourselves. One thing that we did have a problem with during the launch was that there was no way to have two different charges, so a free charge for a VFC vaccine and then a price for a private pay vaccine. But I believe it was probably within a month or so after go live, there was a patch that added it. So we worked with Patagonia, and so now not only does it work for IZ, but any of our meds. Now it's as simple as once you've dispensed your medications, it's one click, and then all of your HCPCS codes, the NEC codes, number of units, everything just gets applied automatically all at once. So when there's far less manual entry, a nurse doesn't need to practically have a code book in front of her to know how to enter all the charges and services she provided.
Yes. And so then, distinct advantages of the staggered launch, and again, that this was not our initial plan. We're able to build on the successes that we experienced in our immunization, maternal, child, and TB programs. Our super users were able to concentrate their support versus being pulled in multiple directions, so it was more concentrated support. Disadvantages, we ended up billing out of 2 systems, and we just closed out the use of our previous EHR. And as Kim and I were talking yesterday, third-party payers have up to a year to make adjustments once you submit your claim. So really, we may be doing work in our previous EHR for up to another year. We also have the problem of having clinical data in 2 systems. So we had risk assessments that were needed, or that ended up being completed manually, and we still have 7 months of data in our legacy system to be migrated over. Also, we had our STD, HIV, and family planning staff needed retraining. Had we known that we were going to stagger the launch, we would not have trained those folks in April. We maybe would have given them a little high-level overview, but it ended up not being a good use of their time at that point. So, ta-da, that brings us to Go Live Part 2. So this time we're doing it for real in all our programs. We had thought or hoped that we would have launched our remaining programs sometimes over the summer or early fall. It took longer than anticipated related to a number of factors. So we had Patagonia Health updates, reports being built, fine-tuning, a lot of going back, dialogue back and forth. Also a big problem for us is that our family planning clinical staff, our nurse practitioners, we have 2 permanent staff, and both of them left between August and November, so that put a definite kink in our plan. So here we are now up to December. We did refresher training with our STD, HIV, and family planning. Have to say I'm incredibly proud of my, well, the whole team, but the clinical team in this part, as well as Brantley's assistants. So assistants, all of our retraining was done internally. Actually, also the whole team. So even the clerical practice management part, because we had to get we call it our central clerical, so they process our family planning and our sexual health clients, so they needed to get retrained as well. So the clerical side went through a 1-day refresher. We did some running of test clients through the system prior to the launch, and we had excellent trainings by Victoria Nicholson Hornblower, one of our public health nurses, who did some amazing training guides and one-on-one sessions with our staff. So then that brings us to January 12th. We launched our STD, HIV, and family planning modules. And then just a little note, the team, so the implementation team, many of the implementation team were here until 8 o'clock the night before the launch, just to ensure that everything was ready to go, making last-minute changes, working on inventory and other miscellaneous issues. So managing staff throughout implementation. So we kind of joke, you know, oh, you thought you could do your real jobs during implementation. So management and Brantley really needed to be completely available for several weeks post go live.
Yeah, so I was off, internally I was Washoe County's project manager, so it was a little like herding cats for me. A few challenges too that we came across right soon after the go live was Patagonia wasn't compatible with our version of Firefox. Or countywide, they tend to use the stable version, so we were on the Firefox. It's called Firefox ESR, so it only gets big feature updates once a year, and so we found that we actually had to get 2,800 users across the county all switched over to a new version of Firefox, but thankfully our tech services department was able to get everyone upgraded within, I think, 2 days.
Yeah, a day or so, yeah.
Yeah. So I guess on a little side note, if there's any IT people on the call, if you do have like any sort of security proxies, any sort of HTTPS inspections or anything like that, Firefox does have some issues with using like your own internal certifications or certs to look at the internet traffic. So we have worked with our IT staff to develop a script that automates getting these certs and stuff installed. So if you do have a very locked down environment, you definitely want to do your research on making sure Firefox will play nicely with your network.
So initially, you know, after we launched, you know, everything was great. I'm touching bases with my supervisors, with some of the staff and clerical, and they're like, yeah, everything's great, but we didn't know what we didn't know. So as more parts, as staff were exposed to different parts and sections of Patagonia Health, we realized that there were some more tweaks or trainings that were necessary. So we did things in real time. The supervisors would have meetings at the end of the day, midday, right after lunch, right at the end of the day, to try and get people up to speed, make some adjustments. We developed some quick use guides as quickly as possible, really in real time to help staff as promptly as possible because things were really evolving quickly. So overcoming our pain points and our fears, you know, again, our on-site demo was like, wow, that was awesome. I think I was, practically, drooling with excitement. I was giddy, really. But then my immunization program supervisor, Linda, she's like, yeah, that immunization widget isn't gonna cut it. It left us desiring a little bit more.
Yeah. So despite not being sure we would go with Patagonia at that time, when Ashok was on site, they sat right there with all of our clerical staff and the nursing staff just to see how we currently worked with our current immunization system. They saw how our Nevada WebIZ system worked and were impressed at the user interface, so they took all kinds of screenshots of that. I would say probably within 2 weeks or so after that happening, we already had like a mock-up, like it was almost like an interactive PDF, just to kind of get some feedback on how we felt about the user interface on it. And that probably went back and forth for probably a good month. And I would say within a release or two after they were here, probably a month and a half or two, they pretty much had a fully rebuilt from scratch immunization module based on a lot of our feedback, and we still weren't even a client at that time.
No, I think as all that was happening, Brantley and I were probably still in the throes of reference checks. I know we hadn't even had the on-site, we had obviously the on-site demo. That's when we discovered there were some issues, but we hadn't gone back to North Carolina, and I really had to persuade my immunization program supervisor, because everybody has more than enough work to do already, right? So it was, we're hedging our bets. I have faith in this. I think this is a system we're going to go with. So I want you to invest a little time now. I think it's going to pay off later, and it really did. Also, I just want to comment that other parts of the on-site demo that we had here were very impressive. The labs, just the overall flow, the billing, the patient reminders, and the dashboards. I was just over the top excited with, I would say the dashboard. So we were really looking forward to using that. So charting, we did have some dual entry concerns, and we did think that we would have better data collection and ultimately better data reporting. One thing that we absolutely do not embrace here at the health district is dual entry. It's pretty much a hard no for us. So we really had to make sure that staff was getting the appropriate information to Patagonia as everything was being developed for us, so that we would minimize data entry and really only have to put it into one system. And then reporting, as we said, we did have some challenges, so that really stalled us out with basically HIV, because HIV is the HIV data that is collected not only in our sexual health program, it's also collected in our family planning program. So that's what really stalled us out with the implementation in sexual health and family planning. And, while it was unfortunate, kudos to Patagonia Health. They worked really hard to meet our very complicated and exact needs. So then we're on to adjusting to their workflow. Again, a lot of managing change. We have your early adopters, and then you have your not so early adopters. As I mentioned previously, some folks, go with the flow. They take it all in during the trainings and give it a try, and then ask appropriate questions. And really, what this pointed out to me is that some of our staff have varying levels of anxiety related to change. So it really is a challenge to manage that. So the electronic super bill, or the ESB management, that was completely new to us. We had never had anything like that. So we worked with Patagonia Health to update our fees based on the description, not the CPT code. So that really saved us, and I think that goes back to what Brantley was talking about in our immunization program, and then it went across our other programs. Also, insurance eligibility verification. Previously to Patagonia Health, we were not doing that at all. When we first started in Patagonia Health with immunizations and TB in May of 2016, we were not doing that at the time of making that appointment. When we launched all our programs in mid-January, we made that a requirement that everybody's insurance eligibility was verified at the time of making the appointment. Also just wanted to comment that billing staff were spending an inordinate amount of time with insurance status at the time of billing, so that was not a good plan. So by doing eligibility verification at the time of making an appointment, that could really save more time, a really good return on investment on the back end. So then our billing system transition, moving to immediate eligibility verification and use of the clearinghouse was completely new to us. We were very excited to see that the average time to claims going out was, well, we could actually see that in a report. We had never seen that before, and they could go up pretty quickly if you have the appropriate staffing level. And then seeing money coming in, and auto posting is awesome. We're trying to get that as automated as possible. And this was far easier than our previous EHR. So thanks in part to Patagonia for having the billing clearinghouse built into the system, as well as our amazing staff that we have that conduct our billing. Just wanted to let everybody know, so for fiscal year to date, so we're not even quite 9 months in, we've posted over $149,000 in reimbursement from third-party payers. And while for us that's super impressive, that's the most we've ever brought in. For reference, in all of fiscal year 16, so what ended last June 30th of 16, we had $93,000 total. So we've already exceeded, and we're not even 9 months into this year yet. And we also, and this is kind of laughable, but in fiscal year 15, we had less than $9,000 in revenue. So we really made tremendous progress. Wanted to just say, that for us, the ESB was very challenging, using both orders and then the assessment in the plan. And if you look more into Patagonia Health, you'll see what I'm talking about. So this was really a learning curve for us. We just realized that we were not using modifiers appropriately, so that added to the complexity. So we really try to, as we learn things, we roll them out to staff as quickly as possible, so it doesn't create more work for us on the back end. And then with regards to teens, there were some complexities for testing for chlamydia, gonorrhea. Also, you may be prescribing emergency contraception. And more often than not, they may have other infections as well. So our managers really needed to know how to review the ESBs appropriately, and ensuring that they know the linkages between the meds, the orders, et cetera, to the ESB. So it really depends on the encounter. So it really can vary from client to client. And obviously, with all of these changes, this changed our workflow in the clinic and also for clerical.
Yeah, so another feature we've moved towards is having all of our scanning and any sort of document uploads all done just in Patagonia itself. Initially, we had a dual process. Our county used a commercial, I believe it's made by EMC, like a data record retention archiving system. So it was very difficult, though, for example, like our billing staff, they would need to have 2 different systems going, because the insurance cards would be scanned in one system, but they wouldn't be in Patagonia, so there'd be a lot of back and forth hunting for documents. So once all the programs got launched, though, we have since moved to doing all of our document scanning into Patagonia, so everything is all in one place, all in their chart. A single system definitely made it a lot easier for the document management. So now, if they ever need a printout of their chart, everything's all right there if they want to take their records with them. One thing we would say, if you're just getting into billing, a super, super helpful hint is always, always, always copy both sides of an insurance card. This is necessary information on both sides of the card. As we've grown and learned how to become medical billers, we found this is probably the #1 piece of information that you need to get your money. I would point out, though, there is one limitation of the scanning in Patagonia, is because since it is a cloud web-based, it's through a web browser, you can't scan directly into Patagonia or other system. Since it's a desktop application, it can just link directly to the scanner on your desk and pulls right into the application. So we had to develop some workflows on programming our scanners to get them to scan to a folder, and then from there you can quickly upload them by drag and dropping browsing for them. So it doesn't have, if your IT Twain driver support per se, so we had to adjust to that. But otherwise, it's been going great for us.
All right, so what we expected and what we did not expect. So as I said before, we really thought that all of our programs were going to launch in May. And then when they didn't go in May, we really thought it was going to be, July or August. And I do monthly board reports for our District Board of Health. And I would say, we're expecting to launch in May, and in July or August. I just quit saying that. It's like, hey, we're still working with Patagonia Health. Everything's going well. We're providing them more information, et cetera, et cetera. So be realistic and give yourself the appropriate amount of time. And we really didn't know what we didn't know. The STD HIV CDC required reporting was way more intense than any of us had anticipated, and it delayed us far longer for not only for the health district, but for Patagonia Health. And then I know there's, if you're looking at appropriate slide presentation, I get a big red F on this one. There's way too much verbiage, but there, I guess I could have split it into 2 or 3 slides, but why? So important elements to ensure success. So start talking about potential change early on and let your staff know, hey, we're looking into new EHRs and we'd like your opinion on a few features. And then keep talking about potential change and why you are doing it. Not only did we fall into a love-hate, which sadly eventually became a hate-hate relationship with our previous EHR, it was also going to age out. And the replacement to us was completely unacceptable and ridiculously expensive. So that just wasn't even an option. So I still needed to, remind staff of that, up until I'd say the last few months. Build a strong implementation team. You need to have a champion, and I would say we've all taken on that role here. We've had to champion different parts and deal with the not so early adopters and some of the naysayers. You need to have your support of your management team. As you can tell, pretty much actually my whole management team, but one supervisor is part of the Patagonia implementation team. We also have the support of not only at the county level our technology services, but Brantley. Brantley was a huge champion, and if we didn't have him, we would have, we wouldn't be here today. We wouldn't be having this webinar. You want to schedule your orientations and your trainings. Keep staff practicing in the EHR. So we did that in immunizations and in TB. We also initially started or kept doing that in family planning and in sexual health, and we discontinued that after a while until we were, later into the fall, early winter, when we realized, okay, now we're going to launch in January. Work closely with Patagonia Health. They're your best ally, really. Work with them to ensure that that the data you need is going to be captured and that reporting will meet your needs. Do this as early on as possible. And then manage change. Again, I obviously have this in here multiple times. Some staff are early adopters and some not so much, and we really need to help bring everybody along. And thank God for our super users. They made all the difference in the world. And that is the end of our presentation. So I think we turn it over to Monique now for any questions.
Yep. Okay. So thank you very much. Both of you guys did a great job. Very enjoyable to listen to. Made it fun. We do have some questions, and I guess I can just go ahead and read those for you, and then you can address them one at a time. But they've been coming in throughout the presentation. So first one is, will you give a brief overview of Washoe County, example, your population served, services provided, and the number of your staff?
Sure. So Washoe County's population is around 430,000 people. And while we don't serve all of them, I mean, public health definitely touches all of those folks. So we are, the Washoe County Health District is governed by a District Board of Health, and we have a District Health Officer who is appointed. He is my direct boss, Kevin Dick. I'm one of 5 division directors. We have community and clinical health services, environmental health, air quality, and epidemiology and public health preparedness, and administrative health services office. We also have the Office of the District Health Officer that focuses more on community health needs assessment, community health improvement plan, and we're working toward public health accreditation. So CCHS happens to be the largest division of any at the health district. We have about 56 full-time equivalents. Our budget is $7.65 million, just shy of $8 million. It's a mix of grant and local funds. When Stacy, in her intro, she talked about needing to do more when we had gone through, I think, an economic downturn. Between 2008 and 2012, we lost about 44% of our staff and 42% of our budget. So it was huge. And while those of us, Stacy and I have been here, 100 years, while we don't want to go through it again, it really, in retrospect, it was kind of good for us. We definitely learned how to work smarter. I won't say that we don't work, smarter and not harder. I think we do both, really. You kind of have to. There are limited funds. Did I answer the question? Sometimes I get going on a roll, and I'm like, what was the question?
Well, he'll have opportunities to ask more.
Okay.
So we'll address the next question is, what organizational needs were not being met by the prior EHR system?
Oh, gosh. Reporting. Reporting and ease of use, ease of posting and billing, cleaning up of financial records. We would start to, I had to finally quit, and God bless Brantley. Initially, we wanted to choke him when he talked about moving to a new EHR, but in retrospect, it really was the right thing to do. We had to stop throwing good money after bad, really. We were trying to invest in new modules to make things better, and the support for, or lack of support for, training and implementation, we just pulled the plug. It's like just take our money and go away. We don't want to use these modules anymore. And so I would say the last year was that of a kind of a standoff, if you will. We did our stuff, they did their stuff, and then as soon as and when I say that general excitement ensued in October of 2015, I think I took the whole team out that night because I was so excited that we were going to be able to end our relationship and move on to a new, and by all accounts, what we could tell at that point was going to be a very healthy and productive relationship. And I will give a shout out to Patagonia, is that they have been impressive from the time that we did our GoToMeeting web demos to their on-site demo, to arranging for North Carolina Health Department demos, through the implementation, follow-up. Sonali was great. She took a genuine interest in our programs, and she would just send like my sexual health team supervisors articles. It's like, hey, I ran across this the other day. I thought you would be interested. So they were gracious and helpful and patient, and really worked to get the appropriate information out of us so that we could be as successful as possible.
Okay, great. And third question is, did the script to PDF process for data extraction completely fulfill the data record retention requirements, or do you maintain a read-only version of the previous EHR?
I would say it met between 80 to 90% of the data we needed. For the most part, at one point in time, my predecessor was pretty much a SQL expert. So he had written a lot of, I think they were called EMR dashboards and
EMR notes.
Yeah, EMR notes and EMR notes and EMR dashboards. And so those already kind of pulled all these various data points into one coherent single sheet of paper or single PDF. So we pretty much just ran like a mass SQL script of these dashboards and then converted them all into PDF and migrated those over to the charts. We're still currently using it because of the lag in the migration, so we still have to figure out how we get that last 6 to 7 month window moved over. But otherwise, there's no new data being generated. It's mostly just reviewing some charts here or there, but otherwise it's predominantly all done in Patagonia now.
Okay, great. Russell, if those don't answer all your questions, feel free to check back in with us. Next question is, when updates or changes are provided, does it only affect the county that requested the change?
I mean, I guess Patagonia can speak to this too. It varies. Most of the features, though, it impacts everybody. But I know when we approach them with, I mean, we're still in constant innovation requests, probably a couple tickets a week we're putting in. But we always approach it with the, rather than it being just about us, we also have to put them in as what we think will work for everybody and can improve workflows for everybody. So for example, the completely rebuilt immunization widget, the automated applying charges for meds and immunizations on charts, the entire HIV widget. I don't know if any of the counties that are on the phone use, it's Luther Consulting, which I think handles the CDC's HIV data collection. So we've built that entire widget, and then it's a one-click report out of all this HIV data that has like 195 columns. So at least the stuff we've put out should be beneficial to everybody. There is some customization, I would say, in terms of like the individual encounter notes that you would use for your charting are specific to your agency. They don't impact everybody. But some of the widgets, just like pretty much any other EHR, though, you're going to be the same for everybody.
Yeah, that's pretty basic answer, and I will add just a little bit to that. Generally, when we have system enhancements, if they're applicable across the board, we would do any customizations that we'd work on with the customer that's working on it with us, and run that as a pilot program for them, and then roll it out where it's applicable to other counties and other states. Sometimes it's a state-specific requirement, which we may work on with the states that are like for Nevada. Other Nevada counties could enjoy those changes and enhancements. Some of the enhancements may be just required from the state, in which case we would roll it out to everybody in that state. But generally, if it's applicable across the board, then it would be for everybody. So the next question is, can you share forms and training manuals?
Yeah, we'd be happy to share any forms we have, and we did get forms from Cleveland County, Jackson County. I think Patagonia shared some stuff with us, and Patagonia had some really good clinical training guides. That's one of the things that we were woefully disappointed in our previous EHR, so Patagonia was really impressive. They shared some basic guides for billing and practice management. We'd love to see something perhaps a little bit more robust, and we'd be happy to share what we have with anybody else. Yeah,
I do know as well through their ticket portal system, there's a wiki as well that has all kinds of directions, anything from like how do you set up a scanner and like a signature pad to how do you chart various types of documentation. So there's also a web wiki that has a lot of this information, as well as there are videos built into the EMR system as well. That's on every page. There's a little red question mark that pops up a video section and pretty much explains how to do a lot of various functions as well.
Yeah, so for any of the training guides, we've had several customers that have created their own sort of short form training guides, quick lookup sort of things, and we can help facilitate that as necessary. So the next question is, how much did you customize the baseline EHR? Sorry. Did you catch that?
Yeah.
Yeah, Brantley's pondering.
Yeah. Okay.
I mean, I guess like the underlying structure hasn't been too much, but obviously the entire IZ interface has been totally revamped. It would have never worked for us the way we originally saw it, but now it pretty much does everything we need. We've been sort of pilot testing barcode scanning, so a nurse can scan the vial or the box, and it knows how to link it together and which NDC to correctly bill. So if you only have a vial, you only have that NDC, but it really needs to be billed out in the way it was purchased, so you need the box NDC. It has that linkage to know how to correctly apply it to ESBs. So we've been working on that. That's still in beta testing with us. I know for sure that's been rolled out to, I believe, all the clients has been the automatic applying of all the meds and IZs that were dispensed all in one click onto the note to get sent over to the super bill. HIV widget, that one was a pretty big undertaking. There was one of their clients was an HIV only center, and so they kind of had something there, but it did not meet the CDC's requirement. So we sent them just huge PDFs that was hundreds of pages long of every detail that the CDC wants and how it needs to be reported out. And so that one's still a work in progress, but I'd say we're probably 70 to 80% of the way getting that one finished, built, and fleshed out as well. But otherwise, for the most part, the standard encounter notes, allergy widgets, patient history, the TB app, we've had some innovations. We came across that, I guess it was built for North Carolina. There's like one of 4 treatment regimens that the CDC recommends for TB, and we discovered that North Carolina uses a completely different one than we use, so we've had that added to the system. So it's more just minor tweaks here and there with occasional big functionality additions.
And then the next question is a bit of a flip side of that question. It says, to what extent did you re-engineer your existing business and clinical processes?
Wow. I would say our biggest change has really been on the clerical side with the making of the appointments and the insurance eligibility verification. During the appointment making, there was a decent amount of complaining and moaning about it, and just said, this is, everybody's job evolves and changes, and this is our evolution and our change, and this is what we're doing, and this is how we're doing it. Because we found that it was taking way too much time on the backside, and then we'd find out that people weren't eligible or they had an inactive account, especially when it comes to ACA plans. So they're enrolled in it, but their account is inactive because they didn't make their latest premium payment, let's say. Another thing that we, I would say that there are some probably smaller clinical changes, but nothing major. And if anything, when we were implementing this with staff, is while we said, we know you have your processes and how you like it, but think about how you might be able to do it newer, better, and different. So not trying to cram Patagonia into our previous EHR version, but now is the time and the opportunity to do things a little bit differently, hopefully be a little bit more efficient.
Yeah, so I would add, though, probably a big change if nurses aren't used to it. With the previous system, we just had paper super bills, and they would mark it up. And then they relied on the clerical staff to pretty much input all the charges and everything like that, whereas now this is all done on the nurse's side. So that was a pretty big change. Some grumbled about it, but I think we've since moved past that. I do know we bought the Communicator app. So before it was clerical, our nurses, when there was any sort of downtime, they had us cold call every single person that would be seen the next day to remind them of their appointments. So now we send voicemail and text reminders, so that has freed up staff resources.
Yeah, we're pretty excited about that. That part's really cool.
Okay. Great. Great. Thanks, guys. The next question is, do you have to use Firefox as your browser? And I can answer that quickly. Yes, we do need to use Firefox. Next question is, since you were functioning in 2 EHR systems, did you maintain a service or support contract with NetSmart?
Yeah, we did not. We terminated our contract with them in December of 2015. So, but since it's a system that we bought and it's on our servers, we have access to everything. So if they did any upgrades or any changes at all, we have no idea. We just went with the system that we had as of December 31st, 2015, and used that for all of 16 in sexual health and family planning, and then cycled out of that in May to Patagonia Health for immunizations, maternal child, and TB.
Yeah, so I would just add on to that, so we don't get any more bug fixes or anything, because now it's pretty much just a read-only database at this point. So I know the server, the SQL server it runs on, is going out of support as of, I believe, January 2019. So that is pretty much going to be dismantled here completely soon.
All right, next question is, it is clear you have been very pleased with the system and process. What is one area where the system or process could have been better?
Linda Gabor, one of our implementation team members, and she is the supervisor for maternal child and immunizations, is gonna, she just came into our conference room, so she's gonna chime in here.
Okay.
All in all, I think for immunizations, we have really, I think, embraced it. Really, the nursing time actually has not increased, even though they're doing a little bit more on the, you know, doing the super bill kind of stuff. I do hear some of the nurses in the other programs that recently launched are still it's taking a little bit more time with the medication component. But again, it's new for them, and they're moving forward, and you know, I think it's getting easier every day.
Yeah, so that was probably going to be about the only thing I would have added is that, yeah, it has the e-prescription functionality, so it does the drug allergies, allergy to drug checks, and all that. But it is a little slower than just being able to click a drop down. Oh, I dispense 5 ibuprofen and then move on. Instead, you have to prescribe 5 ibuprofen, then go back and then actually dispense it. So that is probably the one area that, yeah, has slowed us down a little bit.
Okay. The next question I think I'll have to answer is, are there any New York counties using this product? We do have one county, Otsego County, that has recently signed up. They have not gone live, and I'm not sure what that schedule is, but they are in the process of training and implementation as we speak. The next question is, did you look into any other EHRs besides Patagonia Health?
Yes. I looked at eClinicalWorks. I don't know if I did Epic. I looked at it's like an open source version of the VA software. I can't remember what that company's called. Can't remember the big one.
Yeah, I know. I recall Brent.
It's been so long now.
Yeah, it's been.
Oh, the company that does like the payroll stuff. Not AMC.
I don't know. I just remember Brantley would come to our EHR meetings and he would tell us, "Oh, I reviewed this one, and this one. I haven't found anything that really meets our needs yet." And then he, you know, came in one day and started talking about Patagonia, and we're like, "Okay, let's take a look at it."
Yeah, I mean, it just wasn't. It wasn't like I wasn't unimpressed with a lot of the other vendors. It was just I knew in the back of my head the amount of work it's going to take to get a hospital-grade system that can do pretty much everything, and then just try to cut it all the way down to just the core public health functions was just. I don't think anyone would be up for that task. Only being one person to build and configure the system.
Okay, and then the follow-up question is, if you did, then why did you pick Patagonia Health?
I think that's, I mean, basically everything we said in the webinar. You know, we were just impressed with the company, the level of support, their engagement, their commitment, their willingness to work with us, meeting our needs, and that followed through from the time of the first webinar and on-site demo through, I mean, even today, we've been impressed with their follow-through and their commitment. And they're a good group to work with. They're fun.
Great. Okay, not last question. Were you able to calculate an ROI, and how many months did it take you to recoup your one-time costs?
No, we have not calculated an ROI. Our one-time costs, we spread our cost out over the course of 5 years is our contract. So I would say that while, you know, oh gosh, it's hard to say. I mean, but if you talk, if you think about the terms of our reimbursement from just our third-party payers, and that doesn't include any of the fees that we collect at our counters, you know, Patagonia has been a big part of us being successful with that. So I believe that they will, you know, it just helps our bottom line for sure. Yeah, and how we see it really is every dollar that we can collect from a third-party payer really helps sustain and stabilize all of our clinical programs.
I mean, from a strictly math standpoint, I mean, they're already bringing in more revenue with the integration with the EHR and the clearinghouse than what our yearly contract is.
Yeah.
But yeah, I don't know. They said the one-time cost, it's subscription based or like. So yeah, currently we have a 5-year contract, but yeah, it's an ongoing.
Yeah, so far I think, I mean, you know, I've been here and like, you know, for 28 years, and Stacy said, you know, she helped launch the other EHR. I was not the director at that time, but I had STD and HIV and immunizations, and went through that launch. And I would say that based on the cost of that system, their commitment and follow through, and where we're at, and I know, you know, I mean, I think we're definitely out of the honeymoon stage, but we're early on in this, you know, new marriage, so to speak, is that I would absolutely do it again, and I think it was a very good investment of our time and money, basically our resources.
Okay. I'm going to add just to that too, though, when we do contracts with people, we work with them on payment plans, whether it's an upfront cost or if it's rolled out over the 5-year contract. It's on a case-by-case basis, depending on how you can fit that into your budget. So the next question is, who builds the tables behind the scenes?
I mean, that's probably one of the biggest joys for me is I don't really have to anymore. So most of that's all done by Patagonia. It's not like our old system where you want to like change like a couple things in a widget and it turns into like modifying 20 or 30 different tables, and then we also had custom SQL code that we'd have to test to make sure it was coded correctly. Like I manually had to get into the database and edit SQL code. So all of that I no longer have to do, aside from just more simple adding, removing users, changing some permission levels, and beyond that, though, there's not like, cryptic table configurations at all.
Yep. We have an in-house staff of developers here that manage all of those required changes and customizations and enhancements to the system. So we have had lots of good questions, are all great questions. If you have any further questions, we can stay on the line for a little bit longer. Go ahead and type them into the chat box. I will say that we really appreciate on our end all of the work that the Washoe County Health District did with us in developing the immunization app and the platform that we use today, because it's very different and much more useful, and they were instrumental with all those changes. So again, we really appreciate the partnership with them as well.
Well, thanks. Yeah, we think it was a good investment all the way around. Monique, I'm going to have to leave, but Brantley can stick around a couple more minutes.
Oh, okay, yep. Well, we've got another very nice job. Thanks for sharing comments. So thank you for that. I will go ahead and Yep. Thank you, Steve. I appreciate your input.
You bet.
Okay. Okay. If there are any further questions, then we'll just hang on. And you're welcome. I'm getting a lot of thank yous here. And we will be. We did record the session, so if you want to revisit it again, we'll send that out to you. Also, we are doing a repeat of the session on Friday. If you feel like you need to have other people from your agencies join the session on Friday at 1 o'clock Eastern. So again, that's the same registration link that you used for this one, and we can send that back out. So we really appreciate everybody for joining today. If you have further questions after we disconnect, you're welcome to send those questions to me, and I will make sure that they get answered and help facilitate that. And thank you, Brantley, and also to Steve, who's no longer there. But thank you very much for presenting today, and we look forward to Friday.
Thank you.
Okay.
All right. Bye-bye.
All right. Thank you. Bye, everybody.
Bye.